Hey everyone, welcome again. Dr. D here, bringing you the latest presentation from Beltline Health. Let's get started. Today we want to talk about the post-operative expectations and instructions. This should be a review of your typical kind of instructions on how to go about recovery, and we're going to break it down into details based on this following outline. So I want to cover with you today expectations. Along the way, as we hit each subtopic, I'm going to just give you a general outline of what to expect, and then we'll go into the actual details of the instructions that go in each category. We're going to talk about medications, again, home meds, when should you have restarted some home meds versus not, and then of course the pain medications that I went over extensively in the preoperative visit review. I want to talk about postoperative diet and activity levels and restrictions, as well as wound care, and then when can you return to work. So the first thing about to say about expectations is that, number one, if you haven't already done so, join that Beltline Bariatric Focus and Support group. I always hear good feedback from the people that are engaged in there. You can post your queries with the hundreds of patients that have recently or remotely had a weight loss surgery to see if what you're experiencing has been experienced before. I think that's a powerful tool. Um, we'll usually have members of our team in there replying to, so it's a good place to go through your weight loss journey with kind of your cohort, your group of similar-minded and similar experienced people. So that's number one. I think that's important to do. You'll kind of formulate your own expectations by being in there and engaging in there. And then I want to move on and talk about medication. So just like in the pre-op review slideshow, I discussed the importance of your medications being unique to you and your medical problems. Therefore, when to stop certain medications before surgery is as important as when to restart medicines after surgery. So I'll tell you generally that this is a discussion that should be tailored for you. This PowerPoint in no way should be a substitute for us having gone over this at some point. So if we haven't talked about your medicines that you've been on for a long time at home for various medical problems, your diabetes, your hypertension, your cholesterol, what have you, then that should be kind of triggering alarm bells in your head, and you need to think to call. So we talk about specific things related to you. I'll tell you, generally my goal is after a weight loss surgery to stop as much as I can immediately. Not only is that immediately gratifying, but generally it is actually safe to do so. Just by being on that pre-op diet and that immediate post-op diet, which is kind of low calorie, low carb, high protein, is enough there to immediately rein in some control of your medical problems, especially like diabetes. As long as you're not an advanced diabetic, advanced being been diabetic for many years, and on insulin, for example, you're only on oral agents. Typically, we can stop those, and your body can tolerate a slight, very temporary fluctuation in your glucose levels, assuming that soon thereafter you won't need them at all. So, and also because the diet's low carb, you're not triggering a need for the assistance for those medications. So that's just one example. I tend to aggressively try to stop those medicines because that was, for most of you, a prominent goal, and I like to set you up, not having to need those medicines right off the bat. There's also another reason, your new sleeve or pouch, it may be hard to swallow some tablets. So I'm trying to alleviate some stress on your new stomach or pouch and your rearranged intestines by not putting medications in there if we're getting control of them with the diet and the other things that we've done right after surgery. But I generally will also say, again, individualized to you, if you are a diabetic and we're stopping diabetic meds, I typically want you to check Still check your finger glucoses periodically. If you have 2 or 3 checks in a row that are above 160, I'm going to want you to report that to our office, especially if you're seeing our medical doctor, Dr. McDaniel. You know, he can make adjustments or tell you what to do from there. And if not us, then check in with your primary care. Hey, you know, Beltline stopped my medicine, but I'm finding like I'm having a high glucose, but only occasionally. And then your primary care may say, oh yeah, okay, let's restart, but at a quarter of the dose or a half a dose. So you want to engage with us and or the primary care doctor that takes care of you for management of things of such as your diabetes and your high blood pressure. Same thing with blood pressure. If you have access to it, you can check a blood pressure periodically. As long as that, you know, that top number I say is below the 160 range and that bottom number is below that 90 to 100 range, again, for a few days, it's usually tolerated because you're not eating the normal amounts of salt that your body normally gets. You're not able to hydrate and have fluids on board like you normally have. So people's blood pressure pretty immediately gets regulated just by that. But if you're having high values, or importantly, you know your symptoms of high blood pressure, like a headache, you may feel a little dizziness, blurred vision, you could feel your heart pounding, like that kind of thing. You want to report those things immediately, and I'll probably have you restart that medicine temporarily. Going on to medications, I'm just going to bring this list up kind of quickly. It was covered extensively in the preoperative visit slideshow. These are all the medicines that were sent to your pharmacy. I did put a line through the amend. At this point, that one should be gone because it was for treating nausea, but it was the only medicine you took the day before surgery. All these other ones you should have and you should be using at this point. If you're watching this because you're you're in the post-operative period, meaning your surgery's done, you should already be taking these as we discussed at the preoperative visit. But as a reference, here it is. Again, I hope you're not calling me after surgery saying, Dr. D, I don't have these medicines. You should have them and be taking them like the bottle says. But here again is another opportunity to see that list of 8 medicines that I should have sent. Here is that slide again on pain. Again, I want to reference the pre-op video because that's where I really set the expectations for what to expect. But just briefly, first, again, surgery's going to hurt. If you're seeing this, you're after surgery, you should be sore. I mean, I generally say that pain should be described like this. And this is what I've heard people say over and over. Dr. D, I felt like I did a million sit-ups. Generally sore and tight all over our belly, okay, with an occasional sharp stabbing quality pain. And where will that be? That's typically in one of those larger incisions. If we did extra work there, we pulled something out of your belly there. That's the one site where there's going to be a deep stitch down in your muscle. And if you twisted, like you got confident day 4 or 5, you went to put on a seatbelt. Can't tell you how many times I've heard that story. I was doing great for 4 days. I thought I could drive. And Dr. D, I put that seatbelt on in the Kroger parking lot, and then, oh, I had a sharp pain, like unbelievable. You'll get occasional reminders like that say, hey girl, hey guy, you did have surgery. Let's not forget about it. And I think use that as a tool actually then to guide what activity level you should be following. Maybe that's a reminder that you did a little bit too much too fast. But that's typically how pain should go. We want to target 3 to 6 or 7 out of 10 pain. Reasonable, occasional sharp reminders if you're doing the wrong thing, like a bending, stretching type of activity. I talked about why I try to stay away from narcotics because of the side effects, and that we put you on a great non-narcotic pain regimen, including that numbing medicine Exparel. I then talked about how I think you should, what is your guide through your pain course after surgery? It goes kind of like this with these arrows and boxes. Hopefully you had, like you were like 90% of people in those research studies that had a moderate pain, and you never needed anything else after 3 days. Well, maybe you needed an extra 2 days. You went and got a refill, okay? That didn't quite cover it. What were some of those over-the-counter options? Here's another reminder of those things that you should be trying to manage your pain, again, with over-the-counter meds or non-pain medicine things like heating pads, cool packs. If none of that worked, obviously we want to hear from you. I want to make sure you're not having any alarm symptoms, something that we need to work up, not just we can keep suffocating pain with pain medicine, but I don't want to like be delaying potential need for for treatment. Hey, you're actually having a complication. Well, let's don't mask that. Let's talk about that. So always, guys, again, maybe I didn't say in the pre-op thing, the only thing I want you to collect out of some of this chaos is like the easiest thing for you to do if this is still too advanced, too fast, too much for you to follow, is to just call, okay, and reach out to us so we can talk you through things in a way that's specific to you. I want to explain why things hurt. I've done this talk for people in the past in the general surgery world as well as in a weight loss surgery world, and man, the feedback I got was great. People love hearing and learning about why things are the way they are. So pain can be broken down into a few categories. So one of the types of pain after surgery is called referred pain, and the other types are called general abdominal pain and pinpoint pain. And at least that's how I break them down for people to understand. So let's talk about referred pain first and why it happens. The first pain you're going to have after surgery is actually a very memorable pain. It's like shoulder pain. And the reason that happens is this. The picture here I'm trying to show you, this is kind of what the belly looks like when we're doing surgery. This is the wrong view, technically, okay? This is the best picture I could find, but it's technically a surgeon, maybe an OB surgeon, obstetrician, gynecologist doing pelvic surgery on a female. That's why there's a uterus shown here. But the concept I want you to know is that we have a gas-filled area in the abdomen. So when we're doing these surgeries minimally invasive, it's not like we used to do big incision to make everything open so we have access to everything in your belly. Instead, we make small incisions, but how do we create space inside to work? Did you ever think about that? The way it works is we inflate your belly like a balloon. So what you're seeing here is the abdominal wall, like this is the ab muscles, just to show you, inflated with air. So imagine air down here fills this black space, and it creates a space between our intestines and our abdominal wall. So normally this abdominal wall would be flat down here, it'd be pancaked right against the intestines, okay? And this uterus, there'd be kind of no gap here. But we inflate this to create space to bring in our instruments, like this camera, for example, to look into that space. And then we make other holes to bring in our instruments too. So that's the definition of laparoscopic surgery. Now the gas we use to fill that area, carbon dioxide gas, when it fills up, it not only fills up here in the lower belly as it's shown, it actually fills up here. This is the upper belly in this other picture. So right under your lungs, right under your chest is the diaphragm, and where that carbon dioxide gas is touching, making contact with all this, it's very irritating to the lining of the underside of the diaphragm muscle. Well, the diaphragm muscle has its pain receptors. They follow kind of a highway that has a shared set of nerves from up here on the shoulder. So where the shoulder nerves come in and share highways, or kind of think of an on-ramp. If you're the main highway that innervates your diaphragm, we call it the phrenic nerve, comes from up here, well, there'll be a little on-ramp from the sensory nerves to the skin over here. So because of that on-ramp and that kind of connection point at the brain level up here where everything's processed and put together, it gets a little input from both. It gets a little confused there. So everyone describes, until that gas is cleared, everyone describes kind of a tough, pretty heavy shoulder pain, a pressure shoulder pain that's actually coming from inside your belly. So I think that's worth noting. And that's the first pain you're going to have, and the nurse is going to instruct you to sit up, take deep breaths, maybe get walking as soon as possible. When do we get rid of carbon dioxide from our body? When we're active, when we're taking breaths, when we're walking. And the more you're able to do that, the faster it'll go away. The next kind of pain is general abdominal pain. This is that my whole belly kind of feels sore. And it comes from two sources. It's the actual organ itself, the stomach, for example. If we did a sleeve and I cut up your stomach, it has its own pain receptors. We call them visceral pain receptors. And it's going to be the general achiness in the upper part of your belly. It's really vague. You may not be able to point to it with one finger, right? Like I usually, when I really want to know where someone hurts, I'm like, point to it with like your pinky. You may not be able to do that. You're going to use a whole hand and say like this whole area. Well, that's probably that organ type pain. That's from this level. When I say organ pain, I'm going to point down here. then there's like pain that's going to come from the whole abdominal wall. Okay, so I'm going to start showing you things. So this red arrow now represents the incision I made. First thing I want you to realize is that when we make incisions, it's up here on the skin, but where the nerves run, this is now this blue arrow, blue line, I want you to remember is the nerves. So the main nerves to the abdominal wall come from your spine and they wrap around and they travel in this layer that's technically between two muscles, the external oblique and the transversus abdominis. You just need to know that it's your core muscles, and somewhere in there are these nerves, okay? So realize that the main nerves, they give off little branches that come up to the surface. Some of those branches come up, and some of those branches go down, and they make it to this level of this lining called the peritoneum. That's the last lining before you're inside the true abdomen where the organs are. So that's what's actually detecting that post-surgery pain. So realize that when we make incisions and pass instruments through your belly to accomplish surgery, we are going from out here where the cut is made into your belly, but also realize typically this dotted line indicates a straight shot. That means that where we're doing work is directly under the incisions. That's almost never the case. So realize that actually when we do work, we make an incision on the outside, but we're working at angles, okay? So actually, even if your incision's on the outside, realize that work is being done in another area of your belly. And the reason I show this red line, I think it's critical for a couple of reasons. A, notice that, think of this now as a tract. It's probably where the inflammation and all the healing needs to happen. It has a much longer trajectory through your abdominal wall, through all these layers. And I intentionally drew it crossing these nerve planes. It crosses these branching nerves to the skin, the branching nerves in the muscles, and even down to this level. So if some people get confused when their body's telling them they hurt in an area where the incisions are, well, it's a different kind of pain. It could be that visceral pain, the organ itself telling you it's hurting, but it could also be because that trajectory, that tract of inflammation is different from where you're visually seeing your incisions. Now I want to talk about that exparel tap block. This was a critical component to us getting off of narcotics. At the end of the surgery, or sometimes in the beginning, we put that numbing medicine in your abdominal wall. This is just like when the dentist numbs up your whole jaw so you don't feel them hammering or pulling or drilling, right? So incredible amounts of pain, normally painful things, can be masked by these numbing agents. So someone smart decided, I'm going to mix that numbing medicine up with a solution that allows it to not be broken down very quickly and it dissolves slowly. And they said, well, let's put it in an area where it can act on this nerve for a long time, okay? So this is how I show the tap block. So we go and actually put that medicine, a large whopping dose, like 20 or 30 milliliters of it, in this muscle plane. So it's sitting on the nerve, it's bathing it, soaking in there, so it kind of deadens all these nerves up for a good minimum 24 hours. Sometimes 2 days after surgery, all these nerves aren't really functioning. So all you're really feeling is kind of that first shoulder pain, and then a general like aching, oh, my organs got cut on, that kind of non-specific pain. You can also still, that numbing medicine doesn't do anything to block the receptors from your intestines. So gas pain, when your intestines are bloated, this numbing medicine is not doing anything for that. So as we go through this, I'm going to explain kind of where the pain medicines work and why it's so good, our protocol is so good. So now let's talk about that pinpoint pain and how it relates to how these medicines work. The final bit of pain you're going to have starts about day 3 after surgery, and it's when you're like more aware of your incisions, the actual outside, because now that numbing pain probably woke up. What I'm trying to indicate here is with this black dot, what I'm trying to show you is this. Especially if you have an unhealthy weight, which is probably why you're seeing us, you have belly on the outside that you can probably grab and shift around, right? like those love handles and the extra skin, and that's actually this layer. We're dealing with the layer of skin and soft tissue, this the fat that's pretty mobile. It kind of, frankly, not to be rude, but it jiggles, right? So when you're up and about, just imagine that some of these layers of your abdominal wall can shift around, okay? And when they shift around, it's not just shifting around on the outside, like where the incision lives, it's also shifting around these layers inside. And when it shifts these layers on the inside, you have to realize that it's shifting. Look, I intentionally drew this where the tract is from our work that was done. This is where that instrument went through. So when you're shifting around your weight on the outside, it may be shifting around on the inside and creating kind of a new round of inflammation or irritation. You're very physically kind of tugging on these nerves that are irritated from the recent surgery. So I've already brought into view here one of the drugs, Tylenol, and I want to point out here that Tylenol is acting on this nerve that comes up here to your abdominal wall. It's actually technically acting over here too, some to the lower layers. And that's one mode of pain medicine, right? The next one was gabapentin. It actually acts directly on the nerves to kind of suppress how quickly they transmit signals. So we're affecting the highway. It's like if the nerve is a highway transmitting your pain reception, like the pain signals from where we did surgery up to your brain. Gabapentin may be like, I don't know, like putting speed bumps on the road. So it's like kind of slowing down the signal, okay? And then we have Celebrex. Celebrex is like one of my favorites. Why? It's an anti-inflammatory. It's like a potent version of other NSAIDs like your Advil, your Motrin, your Excedrin, your Aleve, that kind of stuff. But it works better, and it was formulated very smartly in a way where it's less irritating on the stomach lining. So know that any NSAIDs can be irritating. In high doses, I've seen normal healthy adults with full big stomachs get ulcers. And this is why after a bypass, we're going to say no more NSAIDs ever again. If you needed to take an NSAID in a very limited, very seldom dose, if you could ask us, we'll give you some Celebrex. I think that'd be safer. You know what's a no-no? Goodies powders and BC powders. Never take them, even if you're a healthy person, haven't had weight loss surgery. But anyway, Celebrex is going to be in here, kind of working to suppress inflammation along this nerve. So we got Tylenol covering kind of general pain reception and some of those molecules that transmit our pain signals and, in fact, fever signals. They're blocked by Tylenol. And then gabapentin is like the road bumps, the speed bumps on the highway or on the nerve, slowing down its transmission of signals. And then Celebrex is acting on specifically the markers that tell our body that we're in a state of inflammation. It helps kind of keep inflammation down. So there lies three ways we act on pain with that protocol. And realize Celebrex isn't targeting the nerve so much as these other two. It can kind of act in a big space in this whole area where inflammation is. The next thing that popped into view here, this pink color box, I'm trying to show here that this is a lidocaine pain patch. So day 3 or 4, when the pain is, you're more and more aware of the pain up here right at the top of your belly, well, you're going to target that. Realize that these medicines are working under the skin. They may not make it up to the last little bit of pain receptors, but guess what? You put a pain patch on, that medicine is going to act through the skin down. So we're targeting pain kind of from both sides. You see what I'm saying? The next thing I want to show is a green arrow. This green arrow indicates the abdominal binder. Or I also use this to symbolize your heat or cold packs that you put on your belly. Mainly though the binders. So realize that when you get up to be active, that weight's going to swing around. And when it does, again, you're triggering this black dot and these arrows. You're triggering kind of a new insult of inflammation in here. So my thought on how the binder helps is this. This green arrow, imagine pressure pushing straight down on here. That pressure doesn't just stop at the skin. It's transmitted down through these layers so that you have something kind of compressing everything, so there's not as much wiggle room. You can't shift around, and maybe it keeps a little bit of inflammation and some of the nerve irritation at bay. Okay, so that is a multimodal pain control system that I am a big fan of. So let's just count them, like one, two, three drugs. We had that Exparel in here, but in this picture it's gone. Then we did a pain patch. Then we did an abdominal binder or some heat packs to kind of distract the nerve receptors up here. And I didn't even mention it yet, but down here for your gas and cramping pain, you have Gas-X and hyoscyamine for spasms, acting down at this level inside the intestines. And that combined force versus what we used to do, right? So now I'm going to talk about old school. Let's give you a single narcotic. It's purportedly stronger than all this other stuff, but you're going to take it as needed. You're going to wait for pain. So you have one medicine targeting one area versus 3, 4, 5, 6, 7 different ways of addressing the pain. So that's why I think our regimen is better. Please don't kind of scoff at it or us because we're not giving you narcotics. It makes me wonder sometimes what people's relationship is with pain and pain medicine, but overall, I think it's a societal kind of false assumption that we need this strong stuff. We're used to getting it. Mom got it, grandma got it. Let's be young and modern, right? We have a different, better way of doing things as we usually do. Let's move on and talk about the post-operative diet. Here's the expectation. It's very different. You now have a tiny little pouch stomach or a narrow tube sleeve. It's sore. It's been cut on. It's different than what you're used to, and basically it's going to be different, and it's potentially going to be difficult. This is a good time to think about yourself as an athlete. So I love making analogies to athletes and sports because I think a lot of people can kind of wrap their head around that. Maybe you have an athlete in your life, your young kids. Maybe you have you're just into sports. I think it's a big part of our SEC culture anyway. So just this is your period. Like you're going through it. You're gonna go through something. It's gonna be hard and challenging. We just got to keep the other kind of our goals in mind. Okay, your vision of your improved self. Keep that in mind and keep trying to think about how to get there because when it's hard to drink, things taste different. We're telling you got to eat a certain way. You know, you failed diets a ton of times. Why? You probably got bored, didn't taste good. Well, we're going to shock your system and make it easier to be on those things. And frankly, weight loss surgery has been proven through mechanisms we don't fully understand to maybe give you a better taste for some of that healthy stuff. It can really change your taste buds. So you're going to go through it for a little while. Your taste buds are going to change. You may get nauseated looking at something that normally would have given you a lot of like kind of pleasure and good taste and good feelings. And physically it can hurt. And I'm going to explain a little bit about why it can hurt to swallow. Swallow air or swallow food or liquids. So the main issue initially is swelling. It can make what's already a challenging situation temporarily worse. And again, coming back to being an athlete, you hurt your knee, right? You're down on the field. Your goal is to get that fixed and get back into therapy and work hard and get back on it. And that's what this period is for you. You're sore, you're hurting. Feels like your life's been turned upside down, but you got to keep your vision of I love my game. I got to get back on the field for myself, my career, maybe even my support system, my fans, in this case, your family, your children. So kind of mentally be strong and be ready for this part, and the whole process for that matter. But specifically, here's hopefully a explanation why things are initially more difficult than they will be long term. All this stuff will settle down, but represented here is what I think. Imagine your new sleeve tube. If we were looking at it head on, this is what it would look like, okay? This pink represents kind of the muscle layer of the stomach, literally. So it's a round tube. We're looking at it at one section. And look how neatly the words fit in here. Inside the new stomach is shown with that text. So imagine sleeve or gastric pouch. The day I'm finished with surgery, it kind of looks like this. But by starting day 2 or 3, leading into day 7 or 10, that tube, because of swelling, all this, your healing cells, your immune cells are coming into this layer to deal with the stress of being cut on. So it's going to get thick actually. The inside of that stomach is going to get narrow temporarily. So look at you can kind of visually appreciate the edema. I'm going to talk to you about edema if you call me and say, Dr. D, I don't feel good, and nothing's going down. And I always hear this, it feels like it catches right here and it doesn't move. So realize the inlet to that new stomach, before surgery, it was an even bigger circle than this. And now it's the day of surgery, it's like this, but by the time you get home and a couple days in, it may be like this. So yeah, when things are coming from up here and need to enter your stomach, there's gonna be a little kind of a narrowing. We always talk about a bottleneck. There's kind of a bottleneck going on where things are, especially if you took too big of a sip or a bite, it's going to pile up before it can, the stomach lets it trickle in. This is just showing edema. This is not even showing the fact that that muscle that's been cut on in the stomach, it's probably undergoing a little bit of like tightening up to heal too. Just like muscles, when you strain a muscle doing an exercise, throw out your back. We say your back's in spasm. What do you think your stomach's doing? It can be in spasm. It's in a protected healing state. So all those muscle fibers are kind of getting down so that it can be worked on, and then slowly it'll relax. So this is the same font text kind of copied over to give you a sense of, now you can't really see those words because there's not as much space. Well, give it time, take that hyoscyamine, avoid your super cold liquids. Sometimes cold gets the stomach to spasm down and make it feel even more like things aren't going through there. And usually this is what I hear based on, again, phone calls, like by day 7 to 10 and beyond. Patients are like, yeah, I think the worst part's over. It's getting easier. Okay, so it's actually, the timeline is usually this. It's super easy when you're sitting in the hospital. Actually, most people, when I see them right after surgery, are smiling, drinking. I think they get home and they get into this window and this swelling situation. So for a few days it sucks, and people call me like depressed and why did I do this? And then if you've given enough time, usually by that first follow-up and by the time you're seeing our nurse practitioner for the second follow-up, things are getting better. I want to say one more thing though. Just because liquids got better doesn't mean you're not going to experience a little reignition of some inflammation and swelling. As you bump up that consistency of diet to a soft diet and then a regular diet, or you add some big tablet back or a vitamin, that could trigger a new round of kind of swelling and irritation in here. So that's why when I say it's time to advance your diet, I'm usually going to say, like, stick with the program for another week. It's okay to start softs, but like, I only want you to do breakfast only for like 2 or 3 days in a row. Why? I want you to have that breakfast in the morning and make sure it's not kicking your butt through the rest of the day, or even 24 hours later. Sometimes maybe it triggers a new round of swelling that takes 24 hours to peak. So I don't want you slamming in meal after meal and then have a setback for several days, or get to where food could actually get stuck in here if you overdo it and don't do it right. Then you can't even drink. Then you're calling me dehydrated, etc. Moving on, this is the postoperative diet summary. Again, you should have the hard copy or digital copy of your Beltline Health Diet and Care Manual with you at all times. But I copied in the most important table, I think, to get through this initial phase is here in case you need it. The diet stage, of course, pre-surgery diet, that was covered before. Your first few days after surgery, you're going to do the stage 1 diet, which is clear liquids for day 1 and day 2. And then you're going to go to full liquids, which is day 3 through 14. And so on and so forth. So this is key. You got to have your diet manual. If you don't have it, insist on it. It's a pet peeve of mine to hear, like, oh, I didn't read that in the manual. I don't remember that. You've just done a life-changing thing. Please read the manual and refer to it and have it. It's like your new Bible. I kind of already alluded to this from the postoperative diet. When you come see me at the first follow-up, if you're one of those patients that's just doing great, you've actually killed it with the clear liquids, you're having no problem with the full liquids, close to meeting your protein goals, I may go ahead and bump you up to that soft diet. Not immediately that day. Usually I'll say finish out this week on the full liquids, but starting Monday, start with breakfast. And like I said, I like a breakfast only. And the day you start your soft breakfast, start a multivitamin, by the way. But for 3 days, do the breakfast and try a couple different items. Make sure it's going down okay and you feel all right. Then breakfast and lunch for 3 days, and then finally you'll be on a normal soft diet like you should be on that calendar, on that timeline from your Beltline handouts. And plan to stay on that until the 1 month period after surgery, and then I think you at that point you'll be caught up on our recommended diet progression. The subtle difference is if you're doing well, I may bump you ahead to that soft diet a little sooner. Some quick reminders are pointed out here. This is also from the handout, but these are things that'll like really make it better for you, and maybe save you some bad unwanted symptoms and calls to us. So taking your time eating and drinking is key. I know you want to get back to it and you may be back in your work setting, and it's not always, life's not always that convenient, right? But take your time. Don't fight the urge to have that reflexive big gulp or sucking down a big swallow of like liquid and air, because that'll hit your new sleeve or your new pouch and cause you to have symptoms for hours. And then there's some other advice here as you get further along in the diet. I think an important one is not to drink 30 minutes before a meal or during a meal, or even 30 minutes after. That is the key way to avoid a dumping syndrome or symptoms like that. And it's one of the hardest habits to break because everyone is so used to um, drinking when they eat. Activity, what's the expectation? So, like I've been saying all along, surgery is no longer a bed rest type of event. Like, oh my God, my baby. Like, we want you to get back to normal as soon as possible. I'm not saying it's not going to hurt. I'm not saying it's not a big deal. I'm just saying that if you psychologically are preparing for surgery to mean I'm going to be down and out, it's better not to. It's actually better for your outcomes and your recovery in a lot of ways to kind of insist on getting back to normal. So without sounding too insensitive, part of me does want to be a coach again. You're an athlete that hurt your knee, ACL, and you just had surgery. Well, you may get a day or two, but after that, some of these elite athletes are getting into physical therapy almost immediately after surgery. And initially, there was a lot of pushback in that world, in that orthopedic world for that. But now it's the standard of care. You have any knee replacement or anything, they want you to get going. And it's the same thing with us. So return to usual activity is possible within days after robotic surgery and minimally invasive surgery. So we want to take advantage of that. And this is what I typically hear. I think for over 90% of my patients, they will say that they're 90% back to normal by that follow-up appointment at about a week. So hopefully you fit into that category and use that as a guide for how you should be doing. Restrictions. So there are some kind of like hard restrictions here that I tell people to try to follow. Don't lift more than 20 pounds for the first 4 weeks. Don't weight lift. Some people are really enthusiastic, want to use that gym membership or a trainer. I think we surgeons kind of differ in this, but I think there's a role for actually waiting and letting your muscles heal. And actually, it's been proven when you're in this low calorie state that you don't really build muscle anyway. So we're going to put a little emphasis on your walking and a return to cardio type stuff initially. But I don't want you trying to be doing Pilates or lifting weights, trying to gain strength in the first 4 weeks after surgery too. Instructions for walking. At no point until I see you at that follow-up do I want you to walk to where you can't kind of carry a conversation comfortably with someone walking with you. So if mom, dad, spouse, someone's going on a walk with you, you should be able to talk the whole time. You're not like let me sit down at that bench and like catch my breath for 5 minutes. I don't want you pushing, exerting that hard until you see me. So first 3 days, walk regularly in your home after surgery. I typically say walk at least 5 times around your house, living room, garage space, not including bathroom trips. I've had patients say, well, doc, I mean, I walked every time I went to pee. Was that not enough? No, it's really not, and it shouldn't be that way. You can be more active than that. Day 3 to 7, good time to start venturing outside, so like a driveway walk or a cul-de-sac and back. And ideally do this before the peak heat hours and or when it's starting, the sun's going down. In this Georgia heat, in the southeast, it can be overwhelming, especially if you're not getting all your ounces of water. So tailor how much you want to walk to how much you feel like you actually got in your goal intake wise. It's too easy to get dehydrated. Number one reason for calls and reasons to go to an ER is simple dehydration. So we want to avoid that if possible. After the 1 week follow-up, I'll probably clear you for some exercise. I'm going to tell you to go slow but advance. At that point, I'll say you can walk to where you can maybe talk in spurts, and that would be okay, as opposed to, again, walking to where you're so short of breath you can't even, kind of talk to someone. So I'm starting to tell you to do a little bit more, but again, being very cautious, right? I frequently will tell people, you may be mentally, your brain's like, oh, girl, you're good for like 3 miles. Well, don't walk 3, intentionally walk 1.5. Again, make sure it didn't kick your butt the rest of the day or the next day. And then that means you could probably bump up to 2. So whatever your brain says, believe me, I love the eagerness, the enthusiasm. I think going in a stepwise fashion, listening to how your body responds is better than getting way behind and doing something that sets you back or hurts for several days. You know what I'm saying? So typically aerobic exercise, including fast walks, some hills and ellipticals will be okay. Bicycles are okay, as tolerated. Another guide is use your incisions. If your incision gets, you were doing good for several days, suddenly it's like, oh, it's like aches, that means you probably overdid it. So listen to your body. Again, week 4 and beyond, no restrictions and can exercise. In fact, we're going to really encourage that. So your muscles, without getting into like a muscle physiology lecture, we know that resistance training, building muscle, is what allows people to lose more weight. That muscle tends to be more metabolically active. So even when you're resting at night, your muscle is like recuperating, it's burning calories, it's helping you lose weight while you sleep. So beyond that, there's numerous other health benefits to resistance training, especially if you're a lady, in terms of preventing and weight loading and training has been proven to slow osteoporosis and other issues. So take a look at this guide from the American Heart Association. This is your overall, for the rest of your life, this needs to be your exercise goal. And you can have an off week or two, but like, I'm on vacation, but ideally this is what's recommended for good heart health. Let's talk quickly about some wound care expectations. Generally, you're going to have buried stitches. You're not going to see any stitches, and you're going to have a skin glue on top and no bandages. So you may need some extra incisions, typically my sleeve, 5 incisions, bypass switch, revision 6. And don't be alarmed if you wake up and we didn't tell you, or your loved one, like, oh, you said 5, but I have 6, what's going on? We may have added an incision for safety or to get a better angle. And if we're doing revisional surgery, expect drains coming out, but hopefully we remember to expect that, tell you to expect that. And you may have a dressing. If you have a drain, we'll put a specific dressing on it. Instructions will go like this usually when you're leaving. The skin glue is water resistant, but no submerging the incisions until that follow-up check. That means no hot tubs, pools, especially lakes. It's okay to shower. Don't swim or bathe, but it's okay to shower normally. I typically say let soapy water rinse over those incisions, and that's fine. If you very minimally gently want to scrub in between, that's okay. But don't be rubbing all over your incisions. You risk kind of breaking them open. And there you go. And then pat dry. Again, don't rub or scrub with the towel either. And let that skin glue fade on its own. Hey, okay, moving on. Wound care. This is a picture, an example of what incisions look like right after surgery. Actually, this picture was taken of a patient quite some time ago, right as they're actually on the operating room table. The incisions are marked, numbers 1, 2, 3, 4, 5, and 6. And this is just an example of what, kind of to give you an idea of where they are and what they should look like. This is a very typical pattern. I'm just guessing because there's 6 incisions, this was probably some kind of gastric bypass or duodenal switch or SADE surgery or revisional surgery. The key difference being the 6th incision. So if you're having a sleeve or a simple band removal, You're only going to have incisions 1 through 5. You won't have the 6th extra one right next to the belly button. I'll also go ahead and point out that if you're having a sleeve, that tends to be the surgery where something is removed, also a SATI, and a duodenal switch, because all three of those surgeries involve a sleeve, and that portion of the stomach that needs to come out forever is usually brought out through this second incision. And this is a good landmark for where that incision would be for those 3 surgeries. So anyway, what you're seeing here is 5 to 6 incisions across the abdomen. This 5th one is where the liver retractor is. Tends to be the smallest one. The largest one is probably during our sleeve SATI and switch. I estimate it's about 1 inch to 1.5 inches long, and that's to allow removal of the stomach. Sometimes if that portion of the stomach is really quite large, we may have to enlarge this, not only on the inside, so an area you can't see, going back to that pain slide where I showed you the incision outside versus inside. Sometimes we can leave that incision on the outside the same size, but on the inside you have to realize sometimes we're kind of dilating it up through the muscles. We make a separation in the ab muscles and separate those to bring the stomach out. So you may be someone who has a little more pain there because we actually did a little bit more work, a little bit more stretching of that incision down at a lower level that you can't see. But once in a while, I think 1 out of 10 cases, part of the stomach coming out so large that actually I have to enlarge that incision too. Very rarely it's got to be a little more than 1.5 inches long. So that should be the biggest incision for these surgeries. And this is an idea of what the skin glue looks like. This is probably the best illustration. You can see the shiny glare from the flash on the skin glue. The skin glue basically just overlaps that incision by a little bit, and that's it. That's the modern day dressing. Here we have some more examples of incisions after surgery. This is a close-up image of an incision with the skin glue. And around it now you can see some bruising. I get questions about bruising all the time. Bruising is okay. Sometimes there's a little bleeding that happens under the skin level during or after we've closed, and throughout your recovery your body's going to do what it does with blood and reabsorb that. In the meantime, you may get a very impressive, pretty mean looking bruise. Remember, bruises start out dark purple, and then they slowly become a light purple, and then a greenish yellow, and then just a yellow. So don't be alarmed if you see this. Usually it's okay, but of course if you have concerns, feel free to take pictures like this one and share with us. Next, talking about wound care, I like to show some typical patterns of what things look like. Now this is what you're seeing here. This looks bad, but this is a common issue with the skin glue. I say common, but that doesn't mean by any means that everyone gets it. So people who are sensitive to certain adhesives, typically they're the ones that will have a reaction to the skin glue as well. But some interesting features of this, first of all, if you're having a skin glue, basically allergic dermatitis, you're going to experience like mainly itching, not necessarily worse pain or tenderness. And then some features that hopefully are reassuring to you, but in all of these situations, you need to be calling us so that we can talk through it. Is this like some kind of something that requires a treatment, intervention, maybe a visit to an ER for someone else to look at it? Or is it something we can manage? And always know if something doesn't look right, feel right, call us. And in this case of an incisional question, we may have you take a picture with your phone and be ready to email it to one of our secure, like Beltline Health related emails. Ideally, send that picture without any of your personal information attached, just a zoomed in picture of an incision, just like the ones you're seeing on your monitor. But some interesting features. How do we know that it's an allergic dermatitis and not an infection? Generally, the reaction will be limited to where the glue was placed, so it'll follow these kind of perfect patterns centered around the incision. There'll be these raised kind of allergic bumps as the skin is inflamed and reacting to that. This is actually a more classic. So what happened here was, I think this patient had a lot of glue used, and the glue actually, this is the best example. the glue dripped down the patient's belly. So before it dried, probably the patient was positioned or was sat up or something. And then the glue, before it had a chance to dry, look, it followed this teardrop shape down the side of the belly. And everywhere that glue went, so did the rash. So this is a classic example of allergic dermatitis. There's really nothing to do for it except to maybe get some cortisone cream to treat the itching sensation. The first thing I'm going to tell you to do is go ahead and pluck that glue off. The first thing with any allergy, actually in terms of treating any allergy, is to reduce your exposure to that allergen. So it's like if you're outside in the world and you have an allergy, usually we're going to tell you to, a doctor may tell you to go take a bath, get that allergen off of you. It's the same situation here. We want you to peel that glue off. And then it's painful, but you got to just treat through the symptoms of that allergy and the skin, and usually that's anti-itch cream, a little Benadryl or something like that. Going on, this is an example. Again, I'm just giving you examples. I don't mean to give this to you so you can be a doctor and self-diagnose. There's no need for that. You paid for us to do your surgery. We're experts in all this. Please call us and we'll guide you. But the difference between this and allergic dermatitis, just so you have some idea, typically if you have an incision that's truly infected, it's probably forming an abscess under there, and you're going to see kind of a raised bulge like change under the incision. It'll be red. Redness was there with the allergic reaction, but mainly now raised, painful, warm to touch. It'll feel hot, and it'll be more sensitive. You'll go from a period of saying, oh yeah, I'm having that typical soreness at my incisions like Dr. D said I would, to a constant like pressure, constant pain. I mean, if you've ever had a boil anywhere under an armpit or near your buttock region, like you know what that feels like, giant pimple, very uncomfortable, very different from a complaint of itching, I would say. So these are some examples. Raised in red. This one happens to have a white center where it looks like it's ready to erupt. I'll be honest, this doesn't even look like, this is not an incision picture, at least not anything I took. I always reference the sources of these images below, but this is an example of a raised red kind of boil, and just imagine there's an incision nearby, and that's what it would look like. Similar here, raised. You can kind of see the shine on it because the skin's under pressure. Similar here. So these are examples of abscesses, not necessarily, an incisional infection, but there's no reason that it wouldn't look about the same. Okay, return to work. If you're someone who knows you have finicky employers, they need you to do formal paperwork. Usually we talk about FMLA paperwork. Hopefully we've filled that out well in advance and you've let everyone know. As far as expectations, I tell people plan to tell your employer that you need 2 weeks off, okay? And that's to have the maximum time. Most people these days, I'd say 75% of the time, you don't need 2 weeks. Who are going to be people who need the solid 2 weeks and maybe a little longer? It's rare, but like if you're in a labor-intensive job, okay, once in a while I get a factory warehouse type worker. Yes, doctor, I lift heavy boxes. I have to operate heavy machinery. I'm going to tell that person for sure to take 2 weeks off. But 75% of my workers these days are indoors. Think of your teachers or even work from home computer type job. If you can work sitting up, I mean, hell, you're walking right after surgery, so why couldn't you sit at a desk and type? Well, to each their own. So there's patient factors that drive all this. How important is it to you to get back to work? How motivated are you to get back to work? Because maybe you're the only one with employment at your household. You can't afford to take off time. So there's going to be a patient level motivation. Then there's going to be how flexible your employer is. And then there's going to be what are the demands of the job. Those are kind of how we dictate how soon and when you can go back, but really, like, you best. Again, I hope these surgeries, I hope I've done a good job explaining to you that these are the kind of surgeries these days where we can get back to normal function, and I certainly want you to be able to get back to work. So there's those factors that I said. Here's another, in terms of expectations, I get a question like, when is it okay to drive? I'll usually say if you're not on like any medicines where the label says do not operate machinery while taking this, okay? As long as you're not on any medicines like that and your pain's reasonably controlled to where, the key is, you can't hesitate to turn your core to look and look over your shoulder and check your blind spot, right? So when you're confident you can do that and you won't be held back and you're not on any medicines that just have that, the recommendation should be on the bottle if it's one of those meds, then you're probably safe to start driving. Again, everyone recovers at different rates and has a different level of toughness, or let's say sensitivity to all this. So you kind of gauge. So what I'll usually say is you can return to work when you feel ready. Again, if you work from home, you're someone who can log in and do a Zoom meeting. You may be ready in 3 days after surgery. I had someone go back to work the next day after surgery. But then again, they were kind of part-time and they could stay in bed and do stuff on the computer. If you're a teacher or something, if you're a teacher in doing grade school, like elementary-ish school, where you may actually have to like pick up a child and bend and pick up a bunch of toys, a lot of cleaning up to do, then you probably want a full week at least. But I've had teachers go back after a week and not need a full 2 weeks. Especially like middle school, high school, where you're doing a lot of talking from the desk, that kind of level of work. So as long as you can follow the activity restrictions, remember there are only a few hard restrictions. Don't lift 20 pounds, don't bend, twist, or do any heavy lifting for the first week or two until you see me and get cleared. And as long as you don't have a job that requires you to do that, I suppose you can get back to it, and I want you to. Again, shorter leave for sitting jobs. We're going to talk about each scenario that's relevant to you. Um, and of course, I'm happy to sign paperwork. Usually, you don't even need me. We have kind of official paperwork with letterhead, and it can be signed and dated at any point. You don't necessarily have to drive in to do it. We can put it in your portal. But if you need it, we can indicate the surgery date and how much time I think you need off. Some people are ready to get back, but their job does require some light activity. Let's say like a nurse is a good example. Every now and then a nurse really does have to pick someone up. I guess it depends on what floor you're on and what patient population you deal with. But in that case, I've released nurses, for example, to go back to work um, with conditions. So I can say, okay to return to work next week, but for another 2 weeks, I don't want this nurse to have to pick a patient up. We're not doing bed transfers, for example. No, maybe pushing patients in wheelchairs. And then that, usually nursing is hopefully a lot of people's work is like this, but you have a team. So I put that condition, and that nurse said, yeah, I work with a great staff. Like someone will help me out. I'm not too worried about it. So in that kind of situation, you could get back to it too. And there it is. That's what I said in the beginning. Generally, we're going to advise, let everyone know I need 2 weeks, and hopefully they'll be happy to have you back a little sooner. And of course, we can provide paperwork, and you can talk to your coordinator about the longer paperwork, the FMLA, that we definitely takes a little bit more effort. Give us time to do it too. We don't want to upset you or you upset your employer because of delays. But the more time, the more proactive we are, the more we can get all this stuff squared away. Some other items. So at the post-op visit, this is our chance to talk about pathology. What is pathology? That's when, any part of the human body that's removed, generally, we're going to have someone look at that. And what are they looking for and who's looking at it? It's a pathologist. That's someone who went to medical school. It's just that their profession is to look at tissues under a microscope. Basically, what we're doing is looking at that part of stomach that came out, or small bowel if you had a revision surgery, to make sure there was no hidden pathology there. What's a potential pathology? Far less than 1% of all the time, we may say that there was a hidden cancer in that part of the stomach that was removed. And then we may have to refer you to a specialist or have a plan to deal with that. But it's super rare. The other thing a pathologist might notice is that bacteria, that H. pylori bacteria, maybe we didn't eradicate it completely with the antibiotics that we used, or maybe we didn't do that test for you, and this was our first chance to catch it. So this is just a chance, and I'll say it just like this: one order of business. I want to cover your pathology. One issue I've seen lately is your follow-up just may happen to be really early after surgery. So if I did surgery on a Friday, Saturday, Sunday, a pathologist isn't coming in to look at this stuff. And if your follow-up happens to be that very next Monday, they probably won't have the information. So ideally, we go over the pathology at the first follow-up. But please just be a good patient, and hopefully I remember to tell you this. If I didn't cover it, I'm almost always going to tell you at your next follow-up, whether it's with me or a nurse practitioner, be sure to ask about that and try to remind us to look it up and make sure we're not missing anything. And my nurse practitioners and MAs do know for usually within the first month, we all will try to remember and look at that. But again, as a patient, be your own advocate. Try to remember and kind of keep us in check too. So that's what I want to say about pathology. Another thing we're going to cover at your postoperative visit is what are we going to do about the gallstone situation? Remember in the pre-op setting, we talked about gallbladder ultrasound results. When do we like to treat or maybe prevent gallstones from forming? So the classic situation is you had one of those screening ultrasounds. You have no gallstones. You're now out of your surgery. You're drinking liquids. You're doing okay. What I'm going to say is in about a week or two, I want you to start a medicine. It's called Ursodiol or Actigol. And that medicine, it's like 2 capsules a day for basically 6 months. And what we're trying to do is cover you through the most rapid weight loss period of this whole process and hopefully prevent gallstones from happening and hopefully avoid another surgery. So again, be your own advocate. I usually leave notes for myself to talk about it and remind myself to send you that medicine. Every now and then I forget to bring it up. So it's another thing that if you're educated, you're paying attention, you'll say, hey, Dr. D, you know, at the pre-op visit you mentioned that I need to start a new medicine. That may be how it plays out. So anyway, this is another thing that we cover at the post-op visit is what is the plan to try to prevent gallstones. Or if you had gallstones already, we found that on the ultrasound and you weren't symptomatic. Remember, different surgeons have different methods. I tend to want to leave things that aren't causing a problem alone, and I don't want to have overlapping symptoms. So what I'm trying to say is I may have recommended to you that we just wait 3 or 4 months, and if you have symptoms in the meantime, we'll do it sooner, but otherwise, let's get some of that weight off and let's have a nice, easy, safer gallbladder surgery and address those stones. Whereas if you're already having symptoms, it's clearly a problem. Sometimes I'll say, let's take your gallbladder out at the time of surgery. But anyway, if you still have your gallbladder and no stones, we want to send you a medicine or at least recommend it. And we may talk about an interval surgery. So that'll happen at the postoperative visit too. Okay, that concludes our postoperative visit review session. Again, I hope you find this helpful so that you have something to refer to and watch on your own time. And honestly, this post-op stuff, you could watch it anytime after your surgery. If you're in doubts but you're not detecting an emergency, you know, hit this up. See if some of your questions can get answered just like that and save yourself the headache of maybe calling, being on hold, what have you. But always just know that we're here for you. It's your post-op period. We want to guide you through that. We want you to have a smooth recovery, and we have all sorts of resources to help you do that. So don't hesitate to reach out. As always, well, thank you for choosing us and being our patient at this point. And congratulations, you've made it to your post-operative period and your journey is getting started. But as always, also, thanks for coming. If you're just coming to the site or YouTube to get educated, please continue to do so. Feel free to follow us and be on the lookout for new content. Thank you.